So for our side of patients, 10, we just put the antibiotics in. Looks like 9 has a ready bed, so we can call report on that patient. Are there any new patients we should be aware of right now?
Nothing I've heard of yet.
Okay. Sorry to interrupt. I just wanted to update you on a new patient that we just brought right back from triage.
Okay.
He's a 56-year-old male with no significant past medical history, presenting with 1 week of fever, shortness of breath, and persistent cough. He was 70% on room air in triage, so we placed him on 6 liters nasal cannula and put him in room 17, which is a negative pressure room. I think you need to see him pretty soon.
Okay, Julie, thanks for letting us know. Definitely sounds like a patient who's sounds suspicious for COVID. So I'm happy that you already put him into that room. Can you get our entire team ready, including our airway team, and get all of our PPE?
Sure, absolutely.
Thanks.
And just want to confirm, how many negative pressure rooms do we have left in the department?
So we now have 3 in use, leaving 2 available for future needs.
Okay. All right. We'll see if the PAPRs are available for intubation. If they're not, we need to make sure we have the appropriate full PPE. This is a high-risk scenario here. We have someone who likely is going to need high-flow oxygen in order to maintain his saturations, and likely will need to have a breathing tube. So we need to be diligent about our PPE and protect ourselves so we can be there for our patients.
Sounds good.
Okay. All right, let's go.
Hello, sir. My name is Julie. I'm going to be your nurse this morning. I'm going to get started by placing you on our cardiac monitor. How is your breathing with that oxygen?
Not doing too well. It's still hard for me to breathe, it feels like.
Are you having any pain?
What'd you say?
Are you having any pain?
No, not really. And if you could sit me up just a little bit, it'd be great.
Sure. So I did talk to the patient's wife on the phone. She did confirm he has no past medical history, that this really started escalating in the last 2 days. He's been having a fever intermittently, started coughing more and feeling more short of breath today. In triage, it looks like he was in the 70s. We have him on 6 liters nasal cannula, but he hasn't improved very much. So we have respiratory here. I'd like to escalate him to high-flow nasal cannula. I don't think we have that available in the emergency department.
Right now, no. You could do a non-rebreather.
Great, so let's get a non-rebreather. Thank you for putting the mask on this patient. We want to minimize our aerolization. So let's get a non-rebreather, set that to 10 liters per minute. We can put the mask over the non-rebreather mask to reduce any aerolization with this high-flow oxygenation.
Okay. Seems like his airway's intact. He's talking to us.
Great.
He has some diminished breath sounds bilaterally.
Great.
Okay, and he has good distal pulses.
All right, so we have our ABCs. Main focus now is our breathing and ventilation. Sir, we're going to put you on this mask for some more oxygenation, okay? So we'll need to make sure his sats improve to above 92% in order to avoid intubation.
Okay. So he's on non-rebreather now at 10 liters with a mask on top of it.
Great. And access, it looks like we have 2 IVs.
Yes, we have 2 peripheral IVs.
And can we, it looks like we have an 18 in the left and a 20 in the right.
Yes.
And what's our weight on this patient?
He was 80 kilograms on arrival from triage.
Okay, great. All right, looks like our saturation's improved, but only to 89%. I'd like to go ahead and start moving towards intubation for this patient.
Okay.
At 80 kilograms, what RSI medications would you like for him?
All right, so let's do 20 milligrams of etomidate, 100 milligrams of rocuronium for our sedation. Let's do propofol and fentanyl, and then let's have some phenylephrine by the bedside. I'll go ahead and call pharmacy right now.
Great, okay. We can prepare those medications outside of the room and only bring in what we need. That would be good.
Hi, this is Dr. Jane.
Sir, so what we're doing is
When we get a patient
just
on the
go on some
ventilator,
medications
I want
for
to
about
use
6 weeks.
assist control ventilation,
20 milligrams
low
of
stress
sedation,
protocol.
100
We're going to want
milligrams
to
of
use
rocuronium.
6 cc's per kilogram, which would be 450 cc's for this patient at a rate of 16. FiO2, 100%, we keep a 14.
We'll be sure to keep her updated with everything that's going on with you, okay? I'm going to give you some medications that'll make you sleepy so that you do a little bit more comfort during this procedure.
All right, so airway team, I'd like to recap a few important things we want to make sure we do during the intubation procedure because it's a high risk for aerosolization during that. We do not want to use any bag valve mask ventilation before we place the ED tube. We're just going to be using what we have on right now. As soon as we have the tube in place, and we should be using video laryngoscopy for this.
Yep, we have set up.
Fantastic. We should immediately get the cuff up and connect the ET tube directly to the ventilator tubing. I do not want to use the bag valve mask. We have a HEPA filter, viral filter on the ventilator already,
Yes, we do.
and it's distal to the suction.
Yes.
Fantastic.
All right, just to confirm, we will not be using a bag valve mask after intubation. Immediately put the cuff up and attach them directly to the ventilator with the viral filter attached, and we have our video laryngoscopy ready to go.
Great. So quick timeout. We have our medications ready. 20 milligrams of etomidate, 100 milligrams of rocuronium. My apologies.
Yes, 20 milligrams of etomidate and 100 milligrams of rocuronium ready.
Great. Okay, we have our equipment available.
Can I have the end title, please?
Absolutely. Great.
Thank you.
So I believe we're probably ready to proceed. We have meds, equipment. We're all ready?
Yep.
Okay.
All right, so let's push 20 milligrams of etomidate, please.
$20 milligrams of etomidate in.
100 milligrams of rocuronium, please.
Stats are high 80s, so we'll have to move quickly.
Rocuronium is in.
Get ready to reposition the patient.
Okay.
Okay, let's remove his mask and his normal breather.
Just talk me through what you see.
Okay, so base of his tongue, glottis, and we have his chords here too, please. Okay, tubes through the chords. Stylet, please. Can you inflate the tube?
Hold on,
Good.
80%.
Thank you. Okay. Connecting directly up to the vent. The filter is in place. The tube is at 23 at the lips. I'm going to listen for breath sounds. Do you have the tube?
Yes, I do.
I wouldn't be surprised if it takes a minute for the SAS to increase. This patient likely de-recruited quite a bit. With a high peak, we should get him back up.
End title 39.
The patient has good bilateral breath sounds.
Great. Stats are improving. Excellent.
You can hold the tube. I'll sleep through.
I got the tube.
Now that we have the tube in place and have minimalized any aerosolization right now, let's go ahead and think about further workup and disposition for this patient. He's going to need an ICU bed, so resident, I'd like you to notify the ICU about that. When you put the bed request order in, please also be sure on your procedure note to indicate this patient's at high risk for during extubation due to airway edema with coronavirus.
Okay.
We should send off lab work, including a CBC, DMP, D-dimer, troponin, and EKG, and a chest X-ray, confirmed tube, and we'll get this patient to the ICU once that is available.
Okay, I'll call the ICU. I'll put in the chest X-ray to confirm tube placement, and I'll order those medications and those labs for you.